Hola. Buenas tardes a todos. Estamos en la última sesión de este congreso, la sesión del generar, en este simposio Avanzando en el diseño de ensayos clínicos para generar evidencia en nefroprotección en medicina personalizada. Para nosotros hemos hecho con mucho interés esta sesión. Y, en primer lugar, pues bueno, vamos a tener 3 magníficos ponentes y el doctor Martínez Castelao va a presentar al primer ponente.
Bueno, buenas tardes a todos. Como empezamos con 19 minutos de retraso, vamos a tener que acelerar. Así es que yo voy a hacer una breve presentación del profesor Guido Lamberts. Bueno, you don't need really any presentation because you were nominated as an honorary member yesterday. All of us could attend your wonderful talk. All of you know that Guido is not a nephrologist, he's a pharmacologist working at the Groningen University in Netherlands. He's not a nephrologist, but he is one of the best connoisseurs of the chronic kidney disease of any origin, and especially devoted to diabetes mellitus and diabetic kidney disease. So he has conducted many, many important different trials, especially with the new molecules for treat diabetes mellitus, obesity, and chronic kidney disease. And so his personality, his scientific personality is impressive. He has been nominated for the American Society of Nephrology as an honorary member, and yesterday we nominated him as honorary member of the Spanish Society of Nephrology. But overall, the most important thing for us is that he's a friend. He's a friend of the JNDF, he's a friend of the group, Spanish group for the diabetic nephropathy. And in this meeting, he's conducting new trials. And this is the meaning of his talk, because his talk is platform in the nephrology to develop new era, personalized trials in medicines, is here to stay. Guido, thank you very much for accepting our invitation when you want.
Intentaremos acortar la de Vera y un pelín, así se puede acortar un pelín la charla, se puede.
Thank you very much for the introduction and good afternoon, everyone. You are the diehards who stay until the end. Very good. And you will see the best slides because I've kept them for now. We're going to talk about platform trials. But before going to talk about platform trials, I want to go back and reflect on the current therapeutic landscape and think about how we treat patients in clinical practice and how we're going to do that in the future, and then move into platform trials. So disclosures are shown here. So because we know that people with diabetes, kidney disease, metabolic diseases have many cardiovascular risk factors. Often they have high blood pressure, often hyperglycemic, often they have a high cholesterol. Cardiovascular, kidney disease, heart failure is often present. And how do we treat these patients with our current approach? Well, we develop a single drug for a single risk factor. For example, we have developed blood pressure lowering drugs, we have developed blood glucose lowering drugs, we have developed statins, aspirin, etc. But I don't think that's the right approach. I think that the new therapies should target all these risk factors together because they cluster and each of them is responsible for increasing a high cardiovascular risk. And we know that that approach is extremely useful, because SGLT2 inhibitors were developed as glucose-lowering drugs, but they do many things. They lower blood pressure, they lower uric acid, they lower albuminuria, a little bit of body weight, and by combining these risk factors, you can really reduce the risk of kidney disease progression. In addition, GLP-1 receptor agonists do not only lower A1C, they lower body weight, they lower blood pressure, they lower inflammation, they have many other effects, and in doing so we reduce the risk of cardiovascular disease, as shown here, and we reduce the risk of kidney disease in people with diabetic kidney disease. Another issue we have to think about is that if we talk about cardiovascular risk factors and multiple cardiovascular risk factors, then we should not develop a drug for a single indication. We are not developing blood pressure lowering drugs, we are not developing blood glucose lowering drugs, but we are developing organ protective drugs. And these organ protective drugs can be used in many patients, regardless of whether the patient has diabetes or no diabetes, whether the patient has kidney disease or no kidney disease. Because we know that GLP-1 receptor agonists protect the kidney not only in diabetes, but also in non-diabetic patients, as shown here. You see a very nice reduction in albuminuria with semaglutide. This was a SMART study conducted by all of you probably here in Spain. And we see a reduction in blood pressure and body weight. So if you think about that, what about the new incretins? And this is retatrutide. It's a triple agonist. So you have a GLP-1, you target the GLP-1 receptor, you target the GIP receptor, and you target the glucagon receptor. Triple receptors that target the liver, the brain. Triple receptors that target the... Your microphone is on. Triple receptors that target not only the liver, but also the brain, fat cells, and the pancreas. And now what happens if you look at the kidney? Well, this is the pattern that you see if you treat a patient with obesity or type 2 diabetes with retatrutide. I have never seen something like this before. Initially, you reduce GFR up to 12 weeks, and then after 12 weeks, we see an increase in GFR up to 10 mils per minute if we estimate GFR with creatinine. Same with cystatin C, increases in GFR up to 15 mils per minute, and the same if you combine the creatinine and cystatin C. How is that possible? Why does the GFR initially decrease and then increase? Who knows the answer probably receives $1 million from the company Eli Lilly, because nobody knows the answer. What I think is happening is we reduce the fat in the kidney, perirenal fat, so the fat around the kidney, and the sinus fat in the kidney with retatrutide. By doing so, we reduce the compression of the fat mass on the glomeruli. So it's a mechanic compression. If you reduce the fat, you reduce the compression, you increase renal blood flow, and you increase GFR. It's my hypothesis, just an idea. I don't know if this is true, but next week we finish the first mechanistic study with retatrutide, where we have measured GFR, renal blood flow, we've done the MRIs, we've measured perirenal fat and sinus fat, as well as subcutaneous and visceral fat. And that study in 140 people with and without type 2 diabetes with chronic kidney disease will be published next year and presented at the European Renal Meeting next year in Stockholm. We present the design and baseline characteristics next week in the journal Nephrology, Dialysis and Transplantation. A very interesting study. You know probably that the remodel study will be presented at the S.E.N, which is the mechanistic study with semaglutide. This is the next mechanistic study, and probably as interesting as the remodel. I think even more interesting, to be honest. So what does retatrutide do? Again, a single drug that reduces A1C, body weight, blood pressure, cholesterol, albuminuria, specific effects on the kidney. That must translate into kidney protection, cardiovascular protection. So we are conducting, and maybe you're part of that, the TRIUMPH trial in more than 10,000 people. The trial is already finished recruitment and will lead, hopefully, to benefit of kidney and cardiovascular disease. So going back, single drugs should not target a single risk factor, but multiple risk factors. But now the next one is drug combinations will even improve multiple risk factors more than the single drugs. What do we know about the combinations? The combinations is going to be a really important area for the future. Finerenone is a mineralocorticoid receptor antagonist, as you know, reduces kidney failure, and this is the confidence trial where finerenone is combined with SGLT2 inhibition, the first combination trial in 800 people with diabetic kidney disease, followed for 6 months, published in the New England Journal of Medicine, demonstrating a 52% reduction in albuminuria. This was not unexpected, because again, you, or in particular Jose, did already a study with eplerenone and dapagliflozin and showed in 46 patients 53% reduction with the combination. So this shows you that you don't need 800 patients to demonstrate that benefit. 40 to 50 patients is sufficient to already generate important data. And actually, that study was actually the impetus and the motivation for Bayer to do this 800 patient trial. So the small studies that we are doing are giving us pretty good information about new drugs and can motivate other people to confirm those trial results in much larger populations. Also, with combination treatment, as you probably know, there's less hyperkalemia because SGLT2 inhibitors reduce the risk of hyperkalemia. So if you combine the two, you have better benefit. Now, everyone talks about finerenone, and finerenone is a mineralocorticoid receptor antagonist, different from spironolactone and eplerenone because it has these non-steroidal benefits on the mineralocorticoid receptor. But there is another non-steroidal mineralocorticoid receptor antagonist, and this is belcinrenone. And if you look at the molecular structure of belcinrenone, completely different from finerenone. Finerenone is a very large molecule. Belcinrenone structurally is looking similar to eplerenone, but it has a different binding characteristic to the mineralocorticoid receptor than eplerenone. And because of these specific binding characteristics, in experimental studies, it does not increase the risk of hyperkalemia. Because the cofactor recruitment, as soon as belcinrenone targets the receptor and binds to the receptor, there are a lot of other genetic elements activated that lead to a different effect on potassium excretion than eplerenone. And in this study, the MIRO-CKD trial, we tested belcinrenone in combination with dapagliflozin compared to dapagliflozin alone for 12 weeks, and then we assessed effects on albuminuria. I cannot present the results. You have to come to Houston in 2 weeks to see the results. You can also stay at home and read a journal that starts with an L in 2 weeks where you can read the publication. Very interesting data, I think. But we already have some data of belcinrenone in people with chronic kidney disease. This is the MIRACLE study, where belcinrenone was combined with dapagliflozin and tested compared to dapagliflozin alone. And here you see that these higher doses of belcinrenone, up to 150 milligram, reduce albuminuria compared to belcinrenone alone. But we also have learned that the mineralocorticoid receptor can be activated and can have deleterious effects independent of the effects on DNA. And these are the so-called non-genomic effects. So activation of aldosterone, binding of aldosterone to the receptor can lead to production and lead to inflammation and lead to production of pro-inflammatory molecules that then cause damage. So now the idea is we should not only block the receptor, but we also should reduce the aldosterone synthesis. So basically we should reduce the production of aldosterone with the aldosterone synthesis inhibitor. And there are 3 of those inhibitors now in development: baxdrostat, ficerostat, and lorundrostat. Baxdrostat is the one that is now also tested in chronic kidney disease. I presented these data yesterday as well. This is a study in people with chronic kidney disease and hypertension. They received 2 doses of baxdrostat, 1 or 4 milligram, or placebo. And this is the result of the study. As you can see, big reduction in albuminuria. And this trial is now followed, and perhaps you're part of the trial. This trial is followed by ARCTIC, which is the combination trial, again a combination molecule, dapagliflozin with baxdrostat together. Patients are in this study, 2,500 patients are followed for 2 years, and in 2 years from now on, the trial will be finished and we'll see the result, whether baxdrostat in combination with dapagliflozin can reduce GFR decline. Now we know the landscape. We know that there are many new drugs in development, the incretins, the non-steroidal mineralocorticoid receptor agonist, there are even anti-inflammatory drugs in development. How are we going to use them in our clinical practice? And there are 2 key questions that we have to answer. The first one is how to optimally sequence medication. Because currently we use the drugs in the order in which they are developed. RAS inhibition, SGLT2 inhibition, finerenone, GLP-1 receptor agonist for kidney protection. That's what the guideline states. Is that the best approach? Perhaps we should start with the GLP-1 receptor agonist and then followed by an SGLT2 inhibitor. Perhaps we should even specify for which subgroup of patients we have to start those combinations. So find the right drug for the right patients, and here platform trials may be useful. Again, if you look at this order in which the drugs are used, we start with RAS inhibition, but if you then look at the efficacy of RAS inhibition, there's no effect on mortality. There are no other benefits we can expect from RAS inhibition. But if you look at SGLT2 inhibitors and GLP-1 receptor agonists, you get more heart failure protection, you get benefits on mortality, and you have a lot of other benefits. Reduction in hospitalization, reduction in infections, reduction in diabetes prevention. So why are we starting with RAS inhibition? Why are not changing this? Why not start with SGLT2, then GLP-1, then an MRA, and at the end, a RAS inhibitor? I'm a bit provocative, but I think that we have to change the paradigm. The next question is, should we use all these drugs in everyone or find the right drug? And maybe a platform trial can be used here. If you go look at platform trials are basically a combination of a basket and umbrella trial. A basket trial is an infrastructure to test multiple diseases with a single agent. And we know those. For example, the affinity basket. The affinity study is a study of the endothelin receptor antagonist atrasentan in diabetic kidney disease, IgA nephropathy, FSGS, and Alport syndrome. So 4 diseases tested in a single study. The umbrella trial is just something different. You have one disease, but you look at the different phenotypes, specific phenotype of the patient, and then for each specific phenotype, you give a separate drug. For example, you have diabetic kidney disease, and one patient receives SGLT2 inhibition, the other one GLP-1, and the other RAS inhibition. That's an example. Neptune Match is doing that approach. They have FSGS patients, and based on the molecular and biomolecular structure and phenotype, different interventions are used. And now the combination, a platform trial, we test different interventions in different types of patients, and we have an innovative trial design where we have interim analyses ongoing, and every time we test the efficacy of the intervention. The beauty is that each patient can be randomized to different interventions, and this allows you to test specific drug-drug combinations on clinical endpoints. To make that a little bit more clear, this is the Captivate platform that we are currently conducting. We have a standard protocol, and below that standard protocol, we have domain-specific protocols. And in the Captivate platform, we have 3 domains. First one is finerenone, second one is semaglutide, an endothelin receptor antagonist, and number 3, semaglutide. Every patient is randomized to each domain. So a patient can receive finerenone, the endothelin receptor antagonist, and semaglutide. So all 3 of them. If you're bad luck, if you're a patient and you have bad luck, you are randomized 3 times to placebo. And you can have any combination of those. And this allows you, if the sample size is large enough, to look at all the different combinations and compare them to each other. The study is ongoing. We are recruiting patients, and we need 1,000 patients. So it's a big study, it's large, but it is going to be interesting. The next study is even more interesting, and I hope we can spend some time during the discussion to talk and think about this. This is a new initiative I want to launch. It's the ALERT study, albuminuria lowering for EGFR reduction trial. It's an idea I already had in 2008, 17 years ago. In this study, we randomized patients to a standard of care arm and an albuminuria targeted treatment arm. Similar like the blood pressure trials conducted many years ago that used intensive blood pressure lowering versus conventional blood pressure treatment. And in the albuminuria targeted treatment arm, we use a scheme where we start with RAS inhibition, according to protocol, whether it's good or not. We add SGLT2 or finerenone if the albuminuria is still too high. If the albuminuria is too high, after 4 weeks, we add another drug, finerenone. If it's still too high, we add another one. If it's still too high, we add the next one. And I would like to do this. We up-titrate the medication based on the albuminuria levels over the first 6 months, and then we follow the patients for 2 years. When I launched this approach with the companies, Bayer and Boehringer Ingelheim, and I requested, can you sponsor the study with finerenone and empagliflozin? I got an answer within a week. Yes, this is the study that needs to be done. Novo Nordisk is thinking about this. They take a little bit more time, but I want to do it, and I hope you want to collaborate with me in this endeavor. 950 patients. We're going to do it in the Netherlands. All Dutch nephrologists want to do it. We're going to do it in Denmark, in Spain, Portugal, Greece, and Australia. And I hope we can continue to work together on this nice, I believe, nice but important study. So that's the end. I thank you for your attention, and I look forward to discuss this together.
Thank you very much, Guido. And the next talk is últimos avances, terapias avanzadas en incretinas para el tratamiento de pacientes con obesidad y enfermedad renal crónica, de nuestra presidenta electa, doctora Soler. She will be talk about the new advances in GLP-1 in nephrology. This is a new area to explore and to include in more patients. Thank you, Pep.
Thank you very much for your nice presentation. Here you have my conflicts of interest. Why obesity? Why incretins in chronic kidney disease? Because around 40% of our population in Spain, and I think that maybe now more, has overweight, and 22% is obese. It is speculated that 3 of each 10 patients with chronic kidney disease have any kind of obesity. But this was performed years and years ago, before the fast food came to our hands. So I suppose that now we are in a different way, and it's even worse. And the mortality in chronic kidney disease has dramatically increased in Spain, So chronic kidney disease and obesity will be even worse. We already published this nice, actually it was a review paper. Dr. Oscar approached to me, Oscar Moreno, and told me, Pepa, do you think that we can write an editorial about the new drugs and the adipocentric approach in people with diabetes and chronic kidney disease? And he sent me three pages with a lot of information, and I thought, okay, let me ask to the editorial-in-chief of CKJ what is his opinion. And I thought, this is too much. This is too much information. So Jürgen Freude came back to me and said me, this is a really, really good idea. This was published in 2024, but I want a review, not a single editorial. it was just Christmas time, and I called Oscar and told Oscar, they want much information. I think that this was good for us, and we should go for a review. And he told me, I was not planning that. I'm on holidays. I'm just coming on holidays. But finally, we convinced each other, and we wrote this nice editorial where you can see, this is old, but this is already depicted all of the drugs that are now in the market. As you can see in the upper page, and in the upper size, you have the heart failure ones, and in the lower part, the ones that were in chronic kidney disease. And I think that this is a really nice editorial, and I invite you to read this graph, because you have the majority of the drugs that already are now in the market or in the randomized clinical trials that already Guido explaining to you, and I will not like to kill you with all of that information. And if you go to this, just published in Diabetes Care in 2025, with all drugs, all drugs, they demonstrate that if you lose weight or if you gain weight, this is worse for your glycemic control and for cardiovascular and kidney controls. So if we have these new drugs, because you can see here, there is not already semaglutide or the tirzepatide. These are the old ones. So now we have drugs that will work much better. He was talking about retatrutide. We will lose, I don't need to lose that weight, but we will be able that our patient lose at least 20 kilos of weight. So imagine what benefit we can have. This is the SELECT trial, semaglutide in patients with high cardiovascular risk, and this is the kidney sub-study that you already know for sure, with a benefit in the kidney outcomes, and this benefit was independent of the GFR of the patients. This is the SMART study that already Guido told you, and in the SMART study were patients without diabetes and with obesity and chronic kidney disease. Here you can see the summary of the study. They were included 50 patients in the placebo arm and 51 patients in the semaglutide one, and the results were a nicely decrease in the proteinuria, 52% of the patients. What happened with the SOUL study that surprised us a little bit? In the SOUL study, the oral one, they were included 4,000 of patients with oral semaglutide and 4,000 the placebo arm without benefit, but they were patients that were really healthy patients. This is the first, the patients that do not progress. Second, maybe the absorption, I don't think that this was the fact, but the oral has not the same effect. I don't think that this was the problem. And the other is the GFR measurement. They didn't use cystatin, they didn't use ioxol. So here are the results of the SOUL. So when can we now use these treatments? In Spain, we can use these treatments in patients with type 2 diabetes and obesity. And I hope that this will be changed in the future. But why will it be difficult to change this in the future? Because how many people, I say to you, that we have with overweight or obesity? 40% of our population. So we'll see how we manage that in the future. So this is a paper that published in the news, in El Mundo, really nice, showing the increase of obesity in Spain between 2003 2020. So there is a huge increase in the obesity, as you can see here, in men, in male and in female, in Spain. But we do not know in our clinics how is the obesity. And we launched this study that we are collaborating now with the S.E.N also, that is named the Obese Study. And we want to open the door of our clinics, our normal clinics, and and study how many patients do we have with obesity. So the study is almost finished. We already have the data of all of the centers. 2,000 patients have been included, and we will know of these centers in the different part. We pick different parts of Spain, and we will know how many patients that we visit, the nephrologists, have any kind of obesity, overweight, patients with chronic kidney disease. So we'll see if it's 3 of 10, and I thought that they will be much more of 3 than 3 of 10. This is a study that we performed. This is a consensus that we performed with the S.E.N. This was an idea of my friend Jorge Rico Fontalvo with the S.E.N, that is the Latin American Society of Nephrology, the CIDO, the Spanish Society of Obesity, and our society, to try to have a consensus and a classifications for patients with obesity and chronic kidney disease. What, in the meaning that what you do not know, you do not diagnose, and you do not put in your clinical records, and you do not classify, you will never treat. You will never treat. This has been performed for Tangri in chronic kidney disease, but not for obesity. We propose the following classification: obesity, chronic kidney disease, stage 1, without kidney biopsy with hyperfiltration and or albuminuria. Stage 2, obesity and kidney structural lesions related to obesity. Stage 3, another kind of chronic kidney disease. Stage 4, in patients on the dialysis program. And stage 5, kidney transplantation patients. Here, I'm giving you an example, a patient, 58 years, one woman, body mass index 38.86, Alport disease, peritoneal dialysis, and she wants to get a kidney transplant and out of the dialysis program. She came to visit us. At that moment, creatinine and albuminuria doesn't matter. Hematuria was present because she was a patient with Alport disease, and we didn't need a kidney biopsy to perform the diagnosis of this patient. What happens to this patient? We classify obesity, chronic kidney disease, type 4 and 5. And what happens to this patient? When we went to the urologist, the patient say, we do not like to do a kidney transplant, and we are not including this patient in the waiting list. If you do the classification, you go to a personalized treatment. You need to weight loss, cardiovascular risk, and genetic counseling in this patient. What did we do? We classified the patient, we start hemodialysis, we contact the obesity unit to our department, and we started GLP-1 agonists. In June 2022, the weight was 97. We increased to 0.5. The patient lose 5 kilos. 4 months later, we increased to 1 milligram. The patient lose 7 kilos. 5 months later, we maintain the dose, and the patient lose 15 kilos. She was transplanted because she was able to be included in the waiting list without going through surgery. So I think that this is really good for that patient. She started with the diabetes after kidney transplant, and we continue with the treatment that at the end we withdraw, because when we slow down titrate the dose of steroids, the patient clearly improved. So as a conclusion, incretins will be the cornerstone of the treatment in patients with chronic kidney disease and obesity. We recommend classify chronic kidney disease and obesity. What we do not classify, we will not treat, and in the future, triagonist incretins and new treatments will be for sure a clue in the treatment of patients with chronic kidney disease, independent, I'm thinking, of diabetes and obesity, because new trials are coming with these drugs in patients with chronic kidney disease, albuminuria, and non-diabetes and non-obesity. Thank you very much for your attention.
Muchísimas gracias, doctora Soler. Nuestra tercera ponente es perfectamente conocida de todos vosotros. Beatriz Fernández Hernández es nefróloga, trabaja en la Fundación Jiménez Díaz, Servicio de Nefrología, y es una flamante secretaria del GENDIAF, además con una personalidad y un empuje arrolladores. Así que arrolladora es la inteligencia artificial, sea verdadera o falsa, y ella nos lo va a poner claro. Lo que sabemos, lo que no sabemos y lo que ni siquiera podríamos imaginar. Beatriz.
And then I'm going to talk about that in 5 minutes, which is like even better. And I know you know that every one of us have already seen all of this kind of news, like very shocking news about people that already had artificial intelligence tools to describe the ongoing problems and ongoing systems. But there is a law down these artificial intelligence tools, and I'm just going to talk about for 5 minutes about them. Artificial intelligence is defined in different ways, but there are 4 things artificial intelligence has to have: learning, thinking, perception, and interaction. And there are lots of ways of describing artificial intelligence. It can be like Siri or Alexa or ChatGPT or Confident, but it can be totally different. It can be functional, like Deep Blue, that was the one that does the chess tool. It can be an autonomous car. It can have an application. There are lots of different artificial intelligence tools. And I'm not going to talk about those with natural learning processes. I'm going to talk about the ones that are going to help us to improve the assessment of our population. So this is the paradigm shift. This is what we have to change. This is what we are thinking of. We are doing something from the very beginning, like animal models, and then persons, and then randomized clinical trials, and then we'll talk about the patients. But artificial intelligence is doing things the other way around. They took a lot of people with different clusters, with different behaviors, and then they try, the artificial intelligence tool, try to evaluate how these different clusters of people are behaving, so as you can make a decision. And this is doing by different tools. Machine learning and deep learning, those are the ones. And to talk about that, and we can understand, machine learning is that we are going in front of a forest. And we can see the trees, different trees, we can see the pathway, and we can see different things. And in front of these different things, we can describe what we see, and we can try to understand or to evaluate what we're going to do with what we see. But deep learning is just going inside the brain, and it's just going into the forest. So if you go into the forest, you see a totally different pathway, because you are not looking at this, you are already inside, which is even a more interesting tool. So what is the meaning of that? What's the process? What do the artificial intelligence tools or the machines do? They take all the raw data, all the data that you already have. We see all the days, thousands, hundreds, thousands of people. They are different people, but they are not that different. So they can just extract the information, and within this information should be clean, this information should be transformed, and this information should be reducted, so as we can just have 4, 5, or 6 clicks to evaluate what we have in front of us and to have a decision that's going to change the life of this person we are in front of. And we can do that doing from instructions, and we can do that from neural networks. And these neural networks, they are like algorithms inspired in the neural system of a human brain. And they are designed to detect big patterns, like hundreds, thousands of people. And they are extracted the information, and they are also reinforcing this information. So every time you put someone in a model, this model is not only telling you something to do, this model is reinforcing, is eating what you are doing, and then it's putting the model in some different places, and then the model is getting better every time you put a patient into this model. We are the physicians. Okay, we don't have to understand everything that data scientists, data engineers, statisticians, or mathematicians are doing. But we have to understand how they are doing things they are doing for extracting the information we are seeing. We are the ones that are asking about the clinical problems. And this is the main and the most important thing for us. We have to know the prompt. What is the question, the clinical problem and the clinical question? Because with these clinical problems, with this data we've got, they are going to integrate that into a model, into a system, and this system is going to produce a prediction that is what we want to know. I want to know if this person I have got in front of me in my outpatient clinic is going to develop end-stage kidney disease or not. And to do that, they do multiple comparisons. And I'm not going to talk about the multiple or the different comparisons, but when you read a machine learning tool, you read this. And these are the different scikit-learn, the different Python, which is the program, is giving you different things. And you have to understand that these different things are going to be inside a model, and inside this model is going to give you more information. And that is what we have done. We have done in our own population, more than 2,000 patients in diabetic kidney disease. We have detected a model. We compare static models with long short-term models. And we found that there were some different tools that were inside the models that could predict the patient was going to develop end-stage kidney disease in less than 12 months. There were patients that were okay, but they were going to be very much into dialysis in the next 12 months. And albuminuria was not the first one. The first one was creatinine, but albuminuria was inside the model. Yes, it was inside the model, but it was diabetic kidney disease, and it was not the first one. And we already know that there is some people that develop end-stage kidney disease without being albuminuric. And there are some other tools in our model that could enhance this population that had end-stage kidney disease without cross-proteinuria. So what do we use that for? This is another predictive model. And this predictive model can give us a score. And with this score, in the Mount Sinai, they are doing that already in the clinic without putting a bottom. They can make clinical decisions. And their clinical decisions have changed because they just started using this model in their everyday clinical practice. And in this model and on other models, this one is useful, is being used in China with diabetic retinopathy. They can extract models from diabetic retinopathy, and they can extract models from diabetic kidney disease in earlier stages. And with these models, they can predict if the patient is going to develop end-stage kidney disease. And this is the last thing. We need models. Why? We need models to predict. Why? We need models to predict because we want to treat the patients with the best thing we've got, and we want to know what to give to any patient, as Professor Lambert said before. And this is the sample population, and this is what we want to do. We want to adapt ourselves. We want to know how many patients are going to do well or not that well with the medications. Because with all the things we've got and all the data we've got, what we really want to do is to enhance the new treatments and to give the new treatments. But we don't have to give everything to everyone. What we want to know is what to give and who to give the things and what is the sequence of events. And this is something artificial intelligence is going to help us. We've got some challenges. most in those black box of how they work, what's the safety, the data quality, and the medical legal stuff. Because we do not have a proper medical legal environment, worldwide environment for artificial intelligence too, so we have to be aware of that. And this is the conclusion. There's a lot of innovation. We have to be aware of what of all these things are the most important ones for us. Everything is promising. We have to validate, and we have to train ourselves, because we have to be ready for the future. Thank you.
Thank you very much. Gracias, Beatriz, for adapting and for getting some time. I would like to invite the speakers to the table, to the discussion. So, ¿hay alguna pregunta de la sala? Puede coger el micrófono. If there is no question, I would like, Guido, I would like to ask you, Captivate represents a major shift from the conventional clinical trials towards the adaptive, intelligent trials. It's a new era. We're living in a new era. How do you envision this model transforming nephrology and of the next decade? I think what are the main regulatory challenges compared to traditional clinical trials? Sorry, the microphone. For the microphone, yes.
I think that
Okay, no, funciona.
Okay.
Now it's working. I think that for the new therapies, they are often not tested in combination. For example, finerenone, when it entered the clinic, we didn't know whether finerenone would work in addition to empagliflozin. That was why the diabetic kidney disease guideline stated that additional studies are needed to test finerenone on top of SGLT2 inhibition. With the platform approach, we can directly look at these in combination treatments and how drugs work together. I think that's a direct advantage of doing the platform trials. In addition, instead of requiring 3,000 patients, that would have been needed if we would have done 3 separate studies. Now, ideally, we only need 1,000 patients because every patient is randomized to the 3 domains. So it's much more efficient. Because we use interim analyses, we can early stop the study or a domain if there's overwhelming efficacy, or we can stop a domain which I don't anticipate because of lack of efficacy. So that is another advantage. So we try really to make it quicker, to generate faster evidence, and to be more efficient.
Mm-hmm. Thank you.
I've got a question about your last study. And it is about, like, you showed us the standard treatment and the sequential treatment that was. But the patients coming to an outpatient clinic, they are already on standard treatment sometimes. So if we want to involve our population, we have to do a washout period. What do we have to do? We have to just start like randomizing patients, like the standard treatment is going to be okay because they are already on that, or what? How can we do that? How can we start doing this?
Yeah, that's a very good question. I don't think that we need naive patients for this study because it's impossible to do that. So we've looked in our clinic, and about 50% of the patients were only using RAS inhibition. So that means that if we would enroll the other 50%, we would have start with a population that is already using RAS inhibition. There were about 20% that were using RAS inhibition plus SGLT2, and they can also participate. In those patients, if the albuminuria is not controlled, we can add finerenone, we can add semaglutide, and maybe in the future zibotentan or atrasentan. If the patient is already on RAS inhibition, SGLT2 inhibition plus a GLP-1 receptor agonist, there's still room, if the albuminuria is not controlled, to add finerenone or in the future an endothelin receptor antagonist. So every patient can participate because these patients are going to be randomized. So the background medication is probably similar between the two arms, and this makes the trial feasible. It would have been unfeasible if you would have said these patients have to be treatment naive or we start a washout period.
So that's good because we can just add a lot of patients.
Yeah. I hope so. Maria, I have a question for you. You mentioned it's important that we identify people with obesity and chronic kidney disease, because if we don't know the prevalence of obesity, we don't know how to treat it, and I fully agree. But this goes from the assumption that GLP-1 receptor agonists will only work in obese patients. Could you speculate about the benefits of GLP-1 receptor agonists in people without diabetes, overweight, but just like in people with a BMI of 23?
I think that we need more data, but new trials are coming in patients without obesity. And actually, in some of the trials, we are including patients with overweight, between 27 to 30. And in that patients, there is not a significant P of interaction. So it seems that it also works. We'll see how we'll manage.
Secondino.
Thank you, nice talks. Pepa, I would like to comment to you that it's very interesting, your project about obesity with CKD. But the question is that all the ingredients or manuals to manage the obesity should be included change in body composition. The definition of the obesity at this time is fat percent over 25% in the men and 35% in the women. So I think that the project could be a very good success if follow or check the outcomes in the change of the body composition. What do you think about?
I thank you very much. We are only not checking the body mass index in the project. We are also checking the height of the patient and the waist. And actually, we didn't have funding for the bioimpedance. So this is only open the first window. And if we have really different results, I invite you to create projects. But for that, if you need to do the bioimpedance, it's much more expensive.
Okay. Hido, you are a pharmacist in general, we're nephrologists and physiologists, and you are also physiologists. Do you think it could combine in MRA, mineral receptor antagonist, with aldosterone synthase inhibitors could amplify benefits or could be deleterious? What's your opinion? Because nobody has aboard this challenge.
Know that an ACE inhibitor combination with an angiotensin receptor blocker was not so good idea, and I would be very hesitant in combining an aldosterone synthase inhibitor together with the MRA. I think you block the system too much. The aldosterone also, you need some sodium retention, and I think that completely blockade of aldosterone is not a good idea, so I wouldn't do it.
Well,
Yes.
Beatriz, you have been clear that artificial intelligence is not a substitute, but the interpretation could lead to errors, big errors, to apply in our patients.
I don't really think it's going to be a mistake or an error in our patients. I think interpretation is important, but they are already getting better every time you use it. So when you start a model, you already assess the model. So it has more errors. The tools you already have has more errors than artificial intelligence tools, because when you're using artificial intelligence tools, you are not using 100 patients, 200 patients. You are using hundreds, thousands of patients in different parts of the world, and you are like doing models in different parts of the world. So when you are using a prediction tool, a risk equation, or a risk prediction tool, it's not only for Spanish population. It has been using this worldwide. Is when you use ChatGPT. ChatGPT at the beginning it was like a disaster. They had a lot of mistakes. They had a lot of inconsistencies. But it's getting better every day. And there are lots of different tools that they are getting better, because every time you get inside, you are feeding the two.
I think it's very interesting, artificial intelligence, and currently we are using it mainly for risk prediction. What other areas we can use it for? Because I think there's many other areas. Everyone is just focused on risk prediction, but shouldn't we use it for other areas? And my first question. My second question is, when we think about risk prediction, I see that many people take a single measurement and then want to predict what's going to happen in the future. I compared the artificial intelligence models just with a very simple approach, namely you measure albuminuria one time, a week later a second time, you take the average of the two and then predict the risk. And you compare it with the artificial intelligence model that only measured 20 biomarkers a single time. And it turned out that average of the two albuminuria values were better than the artificial intelligence model. So how much gain do we get from these models, and where can we use it?
So there are two things. One is for prediction, another one is for using these predictions to start using different medications. So there are like, when you make a prediction, you say like, this belongs to one cluster. This is one cluster 1, 2, 3, 4. This is the ones that are going to be like terrible. This is the ones that are going to be like okay. This is the ones that maybe you don't even need to enhance the treatment that they're receiving. So if you are in front of someone that has a very high risk, then you will go directly with everything, and that's exactly what you're going to, I think, what's going to be done in platform trials. So if the patient has high risk, you're going to give the patient everything at the same time. But then you have to be like, there's got to be a balance between the money you've got and the money you spend and the benefit and the efficacy for the patient or the futility of the treatment. So if the patient is already in low risk and is well treated with what the patient is taking, maybe there's no need. Maybe the patient can change because life is a changing thing, but you know, it is like that. And the other thing you said was about like the prediction tools. And for example, in our prediction tool, there was not that was not done by ex post and so on. This was static. The one that predicted best for our population was dynamic one. And it was a dynamic system that's called a long, short-term model, and it is being performed by Python and so on. And this model, we feed the model with about 3,000 blood tests. So we use one patient, every patient with themselves in 5 years' time with. I think it was 6 months urinary albumin creatinine ratio, creatinine, uric acid, so everything else. So it was not a static model. It was a model that could predict a little bit better. But again, a lot.
Then I'm not surprised that creatinine was the most important risk marker, because if you just measure creatinine just a week before the dialysis started, because it's a dynamic model, of course the creatinine is the best risk marker, because it's almost creatinine. The dialysis decision is based on creatinine.
But the best risk marker is always going to be dialysis. In all the models, the best is always creatinine. But then there are models with, for example, PTH. There are models with albuminuria. But it depends. For example, when you're using patients with diabetic kidney disease or chronic kidney disease, not glomerular kidney disease, then albuminuria is hard, but not that hard. But when you're using patients with glomerular diseases, albuminuria is getting like very much importance.
Thank you very much for this inspiring presentation and discussion about clinical trials in diabetic kidney disease. And thank you. Gracias a todos por estar aquí. También estará colgado en nuestra web. And I hope to see you next year. Nos esperemos next year. And the Congress is finished. Thank you very much for the speakers, and thank you, Guido.